Now, without further delay, let's begin today's event. Again, sponsored by Dimensional Insight and hosted by Health Data Management. I'd like to introduce your moderator for today, and that is Fred Pizzoli. Fred, you have the floor.
Thank you very much. Welcome, everyone. We're going to talk about the impact that information governance can have on the revenue cycle. And we do have some just special presenters from Sharp Healthcare, and we're really grateful for them to kind of take a deep dive into how this has made a difference within their organization. Would like to present Geraldine Sevenacre. She's Vice President of Healthcare Revenue Cycle for Sharp Healthcare. Joining her on the discussion will be Melanie Betancourt, System Director of HIM and System Integration for Sharp. In addition, Carol Winke, Vice President of Patient Financial Services and Managed Care Operations for Sharp. And finally, our lineup for today, Lori Moore, Director of Data Governance for Sharp Healthcare. We really appreciate them sharing their experience, and we look forward to what they have to tell us. Sharp, you're on the floor. Take it away.
Thank you, Fred. We're excited to be here today. We're going to actually be covering a lot of information, talking a little bit about the introduction to Sharp Healthcare, data as an asset, our enterprise data picture. We're going to share a little bit about our governance model. We're going to talk about the impact on downstream systems, how we address data quality, and what that means to the billing cycle and our patients. We're going to close with what does the future look like. A little bit about Sharp Healthcare. We are a fully integrated healthcare system in San Diego, representing the 3.2 million residents of San Diego County. And I'm just going to keep talking while the blank slide appears. We are 7 hospitals, 4 acute care hospitals, 3 specialty hospitals. We have 3 affiliated medical groups. We employ 19,000 residents of San Diego County, and we also have our own Sharp Health Plan. We have 40-plus locations across San Diego County, representing clinics and urgent cares. Oh, and interestingly enough, of your panel speaking with you today, half of us were born at a Sharp hospital.
Okay. I'm supposed to. He said refresh my browser. Okay.
We're going to cover how data care also means patient care, that in fact caring for the data your facility is a custodian of translates to taking care of our patient population. And Lori, why don't you expand on that a little bit?
Sure. So here at Sharp, we have what's called the Sharp Experience. It's our total care of our patients. It's our philosophy for care. And we believe that data care is an extension of our patient care. It's something that we believe in, that our patient care does not end when somebody walks out of the hospital. It's still part of what we do for a patient even after they're gone from our care line. And you'll forgive us, we're having a little bit of technical difficulty with some of the slides, so we're going to keep trying to move on through. So please be patient with us, and we're all going to just work on our listening skills instead of our visual skills here. So when we talk about data,
Lori, how is data an asset? It's not on the balance sheet.
That's true. It's not on our balance sheet. However, it's something that is both an asset and a liability to every single organization. For us here at Sharp, it means that our data is an asset. It helps us function in all the things that we do, but it's a liability because if it's not good and quality for use, it can hold us back. So that's why we say that it is an asset and a liability.
So what is the size of our data? What is it worth? So at Sharp, we've determined that it is worth $42 billion with a B for just our 2.1 million active patients. And we went through a rigorous exercise in risk and value to patient to be able to understand what this figure, but that's more than all of our other physical assets combined. Mel, why should we care?
Well, Carol, I think it really stems from the fact that data is key. It's the foundation of our quality, of our safety initiatives. Everything that we do with our patients is touched by our data. It affects how we do business, how we make decisions, and how we satisfy all those crazy regulatory compliance things that we have to deal with every day, so we can continue to do business and serve our population well.
I think we're prepping for a poll from the audience.
We are. So we have some excellent questions that we're interested in what people's perceptions are for how data affects revenue cycle and billing. And I think we're going to advance to the first poll question. And we're just waiting for a refresh. Thank you for everybody's patience.
Fred, are you on board with us?
Great. So we have our first question up. First question is, how many minutes does the average American clinician spend looking for correct patient records per shift, per an 8-hour shift? So everybody go ahead and take your best guess. Do you think it's 9 minutes, 18 minutes, 28 minutes, or 42 minutes? Great, and here's our results. So we have a nice spread. Look at that arc. And Carol, why don't you tell them what the actual amount is?
28 minutes.
28 minutes, that's crazy talk. So that means almost a half an hour out of every 8-hour shift, clinicians are just looking for the right data. So that affects how much we can bill, how many patients we can see. That has a trickle-down effect of us spending so much time on using that data that way. Okay, we're going to talk about one more big number. How much money does the average American hospital lose through incorrect billing due to patient misidentification? Do you think it's $400,000 a year, $2 million a year, $11.4 million a year, or $17.4 million a year? Everybody take their best guess. Ooh, we have a much more decisive pattern here for our second question. Carol, why don't you tell them about it?
So this is surprising, but it's actually D, $17.4 million. So, and that is from the 2016 National Patient Misidentification Report from Penniman Institute. So why are hospitals losing so much? Well, let's take a look at some of the reasons.
This is Sharp Healthcare's information system map. These are all the systems that we are interfacing for and with, to and from, data going back and forth to do all the business that we do to run our healthcare organization. So you can only imagine that there are many opportunities for data disconnects, data normalization, information that doesn't mean the same thing in all of these various systems. And we live by cloverleaf, and we like it to function really well. But you're probably wondering, is every single one of these systems related to the revenue cycle? Geraldine, how many do you think?
Well, if I had to guess off the top of my head, first, I think what's interesting about this, Melanie, is that we have 304 different sources for patient health information in this picture of over 600 interface sources at Sharp Healthcare.
And it really makes me wonder that definitions of a patient means the same thing in every single one of these systems.
Well, why don't we take a look at how many of these systems actually carry information either to or from a revenue cycle source. Oh.
And it looks like our animation is not working, but what you would have seen is circles for 24 of those large systems being encircled as revenue cycle touching systems and interfaces.
So how do we ever get anything right? Lori, help us. Well, it sounds like we have a data governance problem here. So what the group has pointed out, so we have 24 different systems flowing into our revenue cycle alone. Each of them comes with different definitions, different structures, different users, and different interfaces. So we have to have a certain methodology about how we bring all of that together. There's no, and we have to do it on an enterprise level. So as you saw in our first slide, Sharp has a lot of different divisions to it and a lot of different ways that they use their data. However, we have to bring this up to a total enterprise system, which is our Data Governance Program Office. Unfortunately, Fred, if you can see, get the animation going so that people can see the total program slide, that would be really helpful. Otherwise, I'm going to keep talking. Thank you, Fred. Oh, there we go. Excellent. Thank you, Fred. So we have master data management, metadata management, data quality management, and policy and procedure. Those are our four main branches we have under the Data Governance Program Office. And I'm going to talk about each one of them and why they're each important for Sharp's practice. So under master data management, what Melanie touched on before, we have lots of different definitions for what is a patient. So we bring them together into one master database, a master list for patients. That's been up and running for about a year. And currently we're working on a master list for providers. So we have an enterprise definition and scope for what is a provider for Sharp. And I'm particularly excited about this one because we're going live in less than 48 hours. So we're right on the cusp of having a model that can handle multiple definitions and multiple masters. Once we get through provider master, we're going to be moving on to location master, which sounds really easy, but when you start tearing it apart, location can mean a lot of different things to different people. First, we're starting out with just physical mailing addresses, our physical buildings in the term of location. However, eventually we plan on expanding location to include things like here's our hospital, floor, nursing station, room, bed. Now, we all know beds can move, so that makes pinning down their location and mastering location a really interesting challenge. But it helps us as an enterprise not just manage our patients better, but helps us accurately move through our revenue cycle.
So Lori, how do you decide on the source of truth in your master data management process?
That's a great question, Geraldine, and I can tell you that it's not always easy to define a single source of truth. We're creating that by coming together and governing our data and bringing it together in a master. We're creating that source of truth. That single source of truth usually comes from a lot of other different sources that align with revenue cycle and those sources you just saw on the previous slide. Now, it comes through, it gets cleaned, standardized, matched, merged, and then posted. So what people used to think of, well, I have all these different sources, where do I go for my information? We have a single source of truth that people can consume.
Can I give a revenue cycle example here?
Please.
One of the things we work with in the revenue cycle is insurance verification. And when we're doing insurance verification, it's not unusual for us to find that the payor has a different name for the patient than we do. And it creates a conflict for us because we want the integrity of our patient file to be as pure and true as possible. But I know that that claim is going to reject if I transmit it to the payor with what I know to be the legal name of a patient, if in fact that payor has a different name on file. Melanie, how did we solve that?
Well, that's interesting because we did identify that early on as a disconnect in information between the legal name and what was coming back in the EDI eligibility response in the 271 that the payer sent back to us because we integrated our eligibility process. And what had formerly been done, and it just makes me cringe when I recall this, we actually were updating the demographic record and the patient record to match what the payer sent back, send the bill, change it back to what we had defined as the legal record, which was based on the identification, whether it was a driver's license, a military ID card, a passport, things that would identify the patient's legal record, and change that back. So that was definitely a practice that we stopped when we realized what was happening with the information coming back from the payer. We created alternate fields on our encounter record. Those alternate fields we call payer name, payer subscriber name, payer date of birth, payer patient date of birth. So we retain the information that we captured from the legal identification, creating the legal record for the patient, but we're still populating the information that the payer has on file in these alternate fields, which are built into the claim form. We have conditional logic on our claim forms that looks to the payer fields, and if they're populated, the claim is created and submitted with that information. If they're not, it uses the information from the legal record. But what this has done is it has eliminated that initial rejection that was received for a claim that wasn't submitted with the information that the payer had on file. So having that information absolutely makes a difference. We preserve our record, and yet we meet the payer needs and get the claim out right the first time and don't cause issues for our patients because we submitted with bad data.
So I could take this example even further. For SHARP, we have about 400,000 managed care lives for which we receive enrollment from various payers, and that name might not match the legal name as well. So in our enrollment record, we've done exactly the same thing, put a payer name, payer date of birth, and when we're submitting our outbound encounters back to the plan receives the exact same information that they gave to the delegated provider so that encounters will go through and not reject.
Right. Isn't it interesting that we've created a process that perpetuates an incorrect name when in fact we do have the legal name and what we know should be the true name? Lori?
So that is a perfect example of data governance, right? It's okay to have multiple names attached to a single patient as long as you're defining them separately and using them consistently. So that is a perfect example of detailed data governance in action.
Excellent.
Okay, so I'm going to talk through some of our other parts of our program here. We've got metadata management, where, again, what we just talked on, that definition of each one of those fields and using them the same way in our business glossary. We have data quality management, where we do some data profiling to see exactly how bad our data is. I would love to tell you that we have pristine, gorgeous, clear water data, but the truth is, everybody knows how bad medical data is. It is human created and therefore inherently flawed. So we are constantly going out there and profiling our data to look for those errors so that we can remediate them through either coordinated cleanup or things with the source system. We also have policy and procedure, where we define roles and responsibilities like data stewardship, data owner. We have policy, and this is also where our data governance steering committee resides, where we make some of those big enterprise sign-offs, and I am very pleased to say that the ladies in the room with me are participating in the data governance steering committee. That brings us to what our data quality focus points are that are kind of relevant to what we're talking about today. And this kind of gives you a list of what we're working on. And I think there's a couple of details that our team wants to dive into.
So all of these focus points are we've all been working on. I just want to touch on one, and I think Jerry Lynn has a hot one she wants to talk about, but email. Emails change, folks change, websites do different things. So it's really been critical for us to, at the front desk, every time ask for the email. And what we're doing with the email, aside from sending information for appointment reminders or other things, the one initiative that one of our clinics has just started to trial and it's having great success is related to the appointment is scheduled. The scheduler, if it's a new patient, will confirm the email. An email will go out asking for a time when the patient can discuss with especially for new patients, a new patient representative at the clinic to be able to get all the demographics and the insurance information ahead of time before the patient actually arrives. So we're looking forward to great success there and having less rejections on the front end from new patient visits.
So what we're doing around email specifically for data quality is we have already kind of done a definition of that, so we're not actively working on the definition. We've kind of wrapped that part up. But we are looking at doing cleanups out there, as well as enhancing what our options are for people to gather emails around our patients. So, for example, in cleanup, where email is sometimes required, if somebody doesn't have an email, it's a free-form field, and people are entering all kinds of dirty data into there. So we're going in there and standardizing that and cleaning that up, and that's an example of our cleanup protocol.
Excellent, Lori. I was going to speak a little bit on the name quality reviews, specifically the twin flag, just because I thought people would find that interesting. At Sharp, it's not unusual for us to have multiple births at any of our facilities, and in a multiple birth situation, it's typically a baby A, baby B, sometimes baby C, D, E. But when you have multiple births like that, it's very easy from a revenue cycle perspective for charges to get commingled, charges being placed on the mother's account instead of a baby's account, on a twin A versus twin B account. So what we've created is a twin flag so that when we actually have a multiple birth in any of our facilities, to ensure that what we're doing around the revenue cycle is of the utmost integrity, we have all of those charge details reviewed and validated before we transmit a claim. So in a situation where we have a multiple birth, we hold those, validate the charge accuracy, and then transmit the claim, just as a way to have a clean claim first pass in the revenue cycle. You also see preferred name, and it is another thing that Sharp does, is if somebody has a name they prefer to be called while they're in the facility, we do record that in the record so that we can call them by the name they prefer to be called and still, again, store the legal name in a place where when we're doing our OSHPD, state, or federal reporting, we have a way to actually transmit the legal name.
Jerry Lynn, I want to build on that concept because address would seem to be a relatively straightforward thing to capture and to transmit in all these various transactions. And yet, when you start bringing in a population of patients that are homeless, and we do have facilities that have a greater than average number of homeless patients coming in utilizing the ED, we submit data, and I'm certain everybody on the line submits data to their various state organizations that tells them what kind of patient population you have, the number of encounters, the types of encounters, the diagnostic codes and procedures that go along with those encounters. And yet, if you submit with an invalid zip code, that hits a threshold. And if the invalid zip code is not paired along with ICD-10 codes that denote homelessness as part of the record, indeed, we have to ask for a variance. And so it's the ability to differentiate between that population of patients that have failed to give a valid address, a valid zip code, versus that population of patients which is truly homeless. So address becomes somewhat more complicated, and for frontline staff, capturing that information, ensuring the accuracy of it, and documenting it has a significant downstream effect on the data that we compile and submit to our state organizations.
Lori, I see we're doing some work on deceased, and there's a cleanup in process. What does that look like?
Sure. So deceased was actually an opportunity for the organization to define what does it mean to be deceased in our system. And sometimes this can be a hard thing to talk about, but it's healthcare, and this is what we do. So deceased, we went out and we did some data profiling, and we realized that 8% of our patients in our largest EHR were aged over 120 years old but did not have a deceased flag on their record. Guess what? They're probably not with us anymore. So we went through and identified some parameters for actually deactivating records that give us a much cleaner view of our patients as a whole in our system. And we're looking at patients who are over 120 years old, who haven't had an activity on their record for 20 years. There's some talk about, well, is 120 too old, too young? I have people who are saying, well, we have longer longevities. So for now, this is our definition, but it's probably a slowly changing one for us. And we'll probably review it and restate what deceased means for us in 5 years. So for now, this is our definition. That will change in the future, and we'll have another retroactive clean out at the end of that.
You know, you're saying that, and that sounds so obvious, but I bet it's something that most people don't think of in trying to maintain the integrity of their master patient index.
It's true. It's true. Okay. So this creates a lot of downstream effects for all of SHARP as well as revenue cycle.
Well, we've talked a little bit about what is a patient and how we define that, and even to the degree of a legal name. And I definitely recall sitting in more than one meeting, and this ended up being a little more controversial than I think any of us thought it would be, is what is the actual document that we use to determine what the legal name is? That is it a state driver's license, a military ID, a passport, a state-issued ID? So it was getting down to the details of what we actually really use, which could be very different from what the patient wants to be called or what the payer has on file. And then you get into the things like immigration or patients that really don't have a lot of information about themselves and their origin. Things like January 1st as a date of birth or July 1st as a date of birth. And what we discovered through some of these processes and what we set up within our own organization is that patients that really don't know their date of birth or that we're not able to guess a reasonable date of birth are entered as January 1st. And a year that we kind of try to get within a 5-year window on either side of where we think that patient may have been born. But it can be rather difficult at times when a patient doesn't know what their date of birth is. But what we also discovered was that immigration does the same thing. But instead of using January 1st as their date, they use July 1st. So if you see a preponderance of patients in an area where you know you have high immigration coming in from other countries, patients may not always be able to document the actual date of their birth. They can get a rough year, or they can say, this is my age, this is why I think this is my age. And they'll come through immigration, either on a green card or when they actually are issued some other documentation, as July 1st date of birth. So then, of course, you have people that really were born on those days because, sometimes those things really do happen. People really are born on New Year's Day. And so, again, it's that differentiation between these placeholder pieces of information that coincide with the real thing. And how do we manage those variances? And I think we touched on it in a previous discussion about entering in alternate fields so that we continue to preserve the legal record in our master patient index, and yet we're still meeting the payer needs to get a clean claim through. So how does this affect our ability to solve for something within our own master patient index? Well, in Southern California, we have a very high Hispanic population. You have a lot of repetition of some kinds of names that are very common. For instance, in our MPI, we have duplicates of 856 Maria Lopez's. Now, I can tell you from a experience that we had here in 2009 that it's not unusual to have these names that are very, very close together that you really have to dig into to know that it's a different person and not the same person. And we had a transplant patient and a patient that was receiving transfusions actually end up in a situation like this where their names were almost identical. Their date of births were identical to the point that the person doing the intake actually thought that it was a transposition. So it's really important when you have these populations that you're able to identify a good way to select the appropriate person, and it really is through data governance and looking at all the definitions that you have and getting the tools and the education to your people so they know what to look for too.
So how does this translate to what happens in Billings? And I think those of us in the revenue cycle really feel like we're the guardians of the revenue for our organization. But from a patient's perspective, the receipt of a bill moves that healthcare transaction from a healthcare delivery experience to a financial transaction. And their confidence in our organization really is going to lie on the integrity of the data that they're seeing coming through in that last piece of communication that comes from our organization.
So it's multiple parties. It isn't just the patient. It's the information that we transmit to their insurance company to ensure that we're sending a clean claim that doesn't turn into a rejection or denial that causes financial harm to a patient. It's information that we submit on our claim and data extracts that go out to government agencies about our encounters. And it's all the other providers that we share this information with who rely on the accuracy of our data about our patient and our encounters to then carry on for their component of their service that they provided to the patient.
So it's a ripple effect. Hospital-based providers, all of those providers, they are going to get this information and they are going to create bills potentially to satisfy the patients and to satisfy the experience, the overall experience of healthcare by submitting a wrong bill. So it's critical to the success. So how does information governance affect the patient pay? So it is the foundation for ensuring we are billing the correct party. PHI, if we submit or pick the wrong patient and then the patient receives a bill that's incorrect and we release other parties' information, that has significant problem for the organization. But patient pay, there's some really good, it's a catalyst for self-service functionality. How are we going to, let's show you what self-service looks like.
Simply visit sharp.com and log into your Sharp account. If you've already completed Sharp's identity proofing process, then you'll see a new billing section on your account page. From here, you can view your current bill and charges, make a payment, and download past statements. We can view our current invoices by clicking the Current Bills and Charges link. a summary of your total balance due is displayed at the top of the page and is broken down by hospital and clinic. Details of your recent visits and invoices are displayed on this page, with the date of service, description, and balance due. You can view details about the service performed by clicking the blue arrow next to the description. When you're ready to make a payment, click the Make a Payment link. You can choose to pay the balance in full or pay for a specific visit. A list of recent visits are displayed and you can choose to pay one or more of them. If you'd like to change the payment amount, click the Change Amount link and enter the desired payment amount. All that's left is to enter my payment details and we're all set. Since launching in October of 2017, over 10,000 invoices have been paid online. In conjunction to the View Statement project, the web team also recently enabled the ability for patients to view registration documents right from their Sharp homepage. Documents include conditions of admission, blood refusal forms, and more. In 2018, the web team will continue working with other teams in ISD to give our patients more engaging and flexible ways to manage their healthcare online. This includes the capabilities to pay by their checking account, set up recurring payments, securely store credit card information to avoid re-entry, and much more. Visit sharp.com/account to check it out.
So we shared that with you as a case study on what works well when you can trust the information in your database. What you just observed was actually built in-house by the Sharp Healthcare IT team. They created that entire patient self-pay portal and the ability for patients to pay online for Sharp Healthcare through the portal. And the outcomes that we've actually seen as a result of the implementation was we've actually seen a 20% increase in payments online. You can see we went from 6% to 26%, and we actually expect that to continue in growth. We've had an overall $600,000 increase in online cash payments. That has translated to an overall increase in my total patient cash of $856,000. So I share that with you to kind of acknowledge that it wasn't just a transfer of payments coming through the mail versus online. We've actually seen an increase in our overall patient cash, which we know some of that lift came with the implementation of our online self-serve patient portals. Mel, you want to share another case study of how we're using our data and opening it up to the public?
Absolutely, and I'm really excited to talk about the open record concept because this is where we take clinical information and data and really use it to alleviate administrative burden for not just revenue cycle team, but also our clinical case managers and our external payer partners. And I think that's where the collaboration between healthcare, whether you're a hospital provider or your healthcare provider, really makes a difference. We had one of our largest Medi-Cal HMO payers approach us about accessing our clinical record directly, remotely, concurrent with the patient's acute hospital stay. And a lot of development later, both technical and process and administrative, and this really took a number of people in our organization and in the payer's organization to achieve. We were able to consolidate our electronic record and present just the clinical information that the external case managers needed to manage the stay concurrently, created a set of reports that were pushed to them automatically, aligned the information so that they knew the patients were there, so it eliminated a manual process. We were no longer faxing data or phone calling data information in, but it actually was transmitted to them electronically to manage the stays concurrently. And where this has always been one of our larger payers, they've definitely needed some hand-holding in relationship to admission notification denials because we would fail to notify the admission timely because we didn't know about it as timely as they needed to know about it, or ongoing management of the care while it was going on, collaborating between the two case management teams. in addition to discharge planning and post-acute care compliance. So this information that we've been able to compile and allow our payer partners access to real time has been transformational for the case management process. And we went live with this actually in August of last year. It was a phased-in go-live, but Lori, if you can advance the slide, I'd love to share these numbers. I'm so excited about this. You can see the pattern of admission denials that we had in advance of our piloted go-live. But it went from, on the average, of 5 to sometimes 25 in a month to 0. And I am so proud to say of the work that was done by this cross-functional team that we have had no admission notification denial since the implementation of the open record for this payer. And that, I think, is significant. And where you really can see the financial impact to the revenue cycle of using our information and our data in innovative ways like the open record on the next slide. Because it has made a difference in the aging and the percent over 90 days or over 60, is this 60? I can't see it, it's 60 days for this payer that we opened our record to. So these is a comparison of our 3 largest Medi-Cal HMOs. And if you have Medicaid HMOs in your state, and I bet you do, they're probably just as difficult to manage in your state as they are in ours. And our 3 largest, you can see red and blue, are still giving us headaches, but green, which is the payer that we went with open record, is actually making some significant progress in reducing our aging dollars and percent over 60 days. So I am extremely proud of what we have achieved here and very much looking forward to expanding it to red and blue.
Mm-hmm. Very nice. So what does the future look like? What are we looking at for how do we want to continue to advance? What are some of the options that we recommend as we move through and move on up? Sounds like self-service has been proven as one of our top options. And it looks like there's a couple of different ways that people can have choices of implementing self-service payment. You can do portals like what we did, but there's also new payment methods coming out like Zelle that we may be able to capitalize on, and some other options that are always coming out. Technology will continue to advance, and we have to take advantage of those as they come through.
And this is working in the revenue cycle because we are confident in our patient authentication. So we have a process in which we believe with a high degree of confidence, like nearly 100% confidence, that through our multi-factor lookup and through our authentication process, that the identification of a patient contacting our system, whether it be through portal or whether it be by presenting to the facility, we can get to a high degree of confidence that, in fact, they are who they say we are. What we didn't actually comment on is when a patient presents at our facilities, we actually do a biometric validation of the individual presenting. So we do use something to identify the patient in our master patient index via biometrics. Through the portals, we actually do a screening process. Carol?
Yes. So we use a credit company that actually asks a series of questions to authenticate the person is who they say they are before they're given access or security into the portal. So we are confident that when the patient is logged into our secure portal, they are who they say they are.
And moving forward with the open record concept, the results with the initial payer were amazing. They are definitely the direction, not just where we want to go financially, but really with our payer relationships. We really want to work in a more collaborative way with our payers and be a lot more transparent. And we believe that in going down that path with our payers hand in hand, it benefits us and it benefits them. The rework we were able to eliminate on our side by reworking appeals and trying to secure payment. the payer was also able to realize they're not having to process PDRs and appeals. And if we can work together and continue that process with additional payers, I believe that that's the next direction for our relationship with our payers in the future.
And I think that bringing their information back directly into our system and populating those key fields that bring in the authorization information, the authorized days, the level of care, are all things that on our future roadmap that we want to be able to communicate two ways with them so that it's not just a one-way street, them accessing our record, but they're feeding us information back, and that lifts it up to the next level for us administratively.
Correct. So that's a big part of the future that we see for healthcare in general is more of a joint responsibility for healthcare data assets. We're hoping to encourage through this transparency of portals and open records that our patients will start to take more responsibility for looking at their own data quality instead of the one-way street that it feels like today. We're really looking for that two-way street of responsibility for taking care of healthcare data assets in general. So we're going to leave you with just something fun. Data cleanliness is key here at Sharp. We hope it is for you too. But like in the cartoon, we're ready to scrub the data. I think if it was as easy as getting a bucket and a mop, we would all have them and we would be scrubbing our little hearts out. It does take a lot of coordinated effort between IT and between the business and between finance, and it takes an awful lot of coordination, and we hope we've inspired you to find that coordination path for yourself today. Thank you.
Great. Well, thank you very much, Sharp. We appreciate the presentation and some of the great things you've been learning. We'll have some time for questions and answers in just a minute. If you have any questions, please do submit them. Right now, I want to introduce George Deely from Dimensional Insight, who's going to be telling us a little bit about some of their services and how it fits into this topic. George?
Thanks, Fred, and thank you to the Sharp team, Geraldine, Melanie, Carol, and Lori for a very engaging, informative, and thought-provoking presentation. We're excited to be part of the discussion around revenue cycle management. Dimensional Insight develops analytics technology and solutions for healthcare, and as we've heard today, data and analytics is an integral part of managing the revenue cycle. And in working with our customers, we've identified 3 steps that have proven to be effective in getting analytics right. And they can serve as a good starting point. So I wanted to share those with you. First, there's integrate the data. The integrate, clean, and validate stage. That provides a foundation of high-quality information to build on. There's no shortcuts here. It's important for that foundation to be solid as a starting point. Next, there's govern and engage. It's essential to get subject matter experts and stakeholders together to agree on and document the measures or KPIs that you'll rely on to manage and then continuously optimize the revenue cycle, as well as other processes. That's what ultimately engenders trust in data and promotes understanding. And collaboration is really important here, as you've heard from the Sharp team. Then finally, there's act on the data. Just having it doesn't get you results. And as we've seen today, you need to put the information to work to understand your processes, identify opportunities to improve outcomes, and then relentlessly monitor progress. Sharp's story on the impact of open records on admission denials and other revenue cycle KPIs is just one example of what's possible. Earlier this year, we conducted a survey of revenue cycle management challenges facing health systems in conjunction with HIMSS. We'd invite you to download that from the Dimensional Insight website. You can see the URL here, as well as in the slide deck that you can download. There's lots of interesting insights here, very consistent with our discussion today. If you'd like to learn more or continue the conversation that we've started, I'd be happy to do that with you, and here's how you can get in touch. Thanks, and back to you, Fred.
Sure, thank you, George. We do have some great questions that have come in. I'd like to just throw them out here for the SHARP team. Here's one. What role does your MPI team, those who are addressing duplicates, merges, etc., play on this data governance program office, if any?
Sure. So it's directly linked. So when I first came on board at SHARP about 2 years ago, when we were starting to spin up the patient master, Melanie here had the brilliant idea to go ahead and move the MPI department, literally, or actually it was a team effort, to move the MPI department over to the data governance program. So actually we perpetuate all of the data governance principles through the MPI team for every single merge we do, every single deduplication we do, every single piece of cleaning that we perform on our patient data as we touch it every single time. So we have a dedicated MPI team. We're actually one of the few hospitals where if we have a patient that comes in and there's an accidental duplicate record created for that patient, a doctor realizes that has happened in the system, they actually call our MPI department. We do a live deduplication effort, and the nurse knows exactly how to go and cut off somebody's wristband and reissue the correct wristband with the new merged record live while the patient is with us and while the care stream is going. So that is a service that our MPI team can do, and they do it by using some fairly aggressive data governance standards as they move through that process.
Lori, I'm going to add to your question, and I'm going to toot MPI's horn a little bit because we have a health information exchange in San Diego County that SHARP Healthcare, along with other large healthcare organizations, are participating in. And our MPI team, our manager for the MPI team, actually is participating on the panel that governs a lot of the decisions around Master Patient Index and is looked to as a subject matter expert and best practice implementer. They actually go to her to see what it is that we're doing here at SHARP Healthcare. She's been very key and instrumental in driving a lot of the data matching, data cleaning that even goes on through the HIE.
Correct. So, Lori, how many merges do you do, and how many downstream systems do you touch when you have to do a merge?
Sure. So when we do a merge, there's a range depending on the source that that duplicate is in. It's anywhere from 3 to 5 systems. So we have people manually touching data in 3 to 5 systems. We handle about 30 to 35 duplicate pairs per year for our team of about 9 people. In addition to that, we have about 800 overlaps per year. An overlap takes us about a day to unstitch and make sure that we're all clean and clear, and a duplicate takes about 15 minutes. So that's why the rates are so different. We actually track every single one. We track where they come from, they track how they were created, and we produce reporting and KPIs around who's doing what with our patient data when it comes to safety and quality and patient identification. So we do quite the gamut. Do you guys have any other questions?
We do. One question that came in is, what system or systems do you use for your scheduling and registration ADT functions?
Right now, SHARP Healthcare is using Centricity Business Systems.
Okay. Great. One other question that's come in. For the bill pay, is the actual ICD-10, CPT, and HCPCS code listed for the patient bill? This questioner says, I find most of the time an itemized bill isn't available, only a full amount that's owed.
So on the clinic bill, the listed procedures along with the procedure code, the description and the procedure code are listed on the statement. It's a viewable statement, and we do provide that information on the statement. And on the hospital patient statements, we actually summarize by revenue code. but we do not list the CPT codes and we do not list the ICD-10.
And is that something you determined by research or customer question and answer surveys?
It's the cleanest way to get a good, concise information to a patient. The detail on a hospital bill could run 20 pages if we ran that level of detail. It's available, charge details available on request, but on a statement, we want to make sure they just know what comprised of the total charges.
Mm-hmm. Okay. Just one more question here. What kind of techniques do you use to automate the data cleanup process, and how often do you profile your own data?
Sure. So we do have a cycle of data profiling. We usually do it about once a month, but there are certain things that we look at more often than that and certain things that we look at only once a year. And we do have a data governance and data management set of tools that we do that for our ETL work, for our data quality work, for our master data management work, and we profile them. And our data cleanup process at this time, we're not automating that. Right now we're being very mindful about what that looks like, and we don't have a process by which we go in and we blanket update. Every single one of our updates goes through Data Governance Steering Committee for sign-off before we execute them. That's because we're still in a little bit more of the earlier stages of automation. I think once we have most of our masters up and running and a little bit more stable, we will be automating some of those things and some of those write-backs that come out of the master files. But as of today, it's still a manual cleanup process for us.
Okay. Well, excellent. I guess we are right at the very top of the hour. It's been a great discussion, at least a chance to see some of the work that's involved in this and some of the payback. So thanks to Sharp Healthcare for taking the time to share their collective wisdom with us. I also wanted to thank George Deely and Dimensional Insight for their participation. And thank you all for attending this webinar, and we appreciate your participation as well. I want to end this and wish you all a good rest of your day and week. Thank you very much.
Thank you.
Thank you.